Welcome from all around the world to Peripheral Interventions Live, broadcasting today from the Cardiac Catheterization Lab at Mount Sinai Hospital in New York City. Let me introduce myself. My name is Dr. Peter Ferrugia. I'll be your moderator for the day, guesting here live at the Cath Lab. We're going to see how we do today. I'm coming in from New Jersey. Came in from Monmouth Medical Center, the director of the Cardiac Catheterization Lab there, working for Robert Wood Johnson Barnabas, and very proud to be here today. The video of this broadcast will be available on the website later today. The last broadcast from September the 25th, as well as previous peripheral cases, are available now on www.ccclivecases.org. We'd love to hear from you today, so please email us any of your questions directly from the www.ccclivecases.org website, or email us at ccclivecases@gmail.com.
Good morning, everyone. Most of you guys know me. I'm Karthik Guja. I'm the Associate Director here at the Mount Sinai Endovascular Program. So without any further delay, we'll go to the Cath Lab where PK and Dr. Krishnan and Dr. Kapoor will be waiting for us with an interesting case here. Good morning, Dr. Krishnan. Good morning, Dr. Kapoor.
Good morning, everyone. We'd like to welcome Dr. Ferrugia as our guest moderator today. It's really an honor to have him. For those of you who don't know much about Dr. Ferrugia, he's an extremely well-respected person in our community. He's the medical director of the Cardiac Cath Lab at Monmouth Medical Center in New Jersey, a busy peripheral interventionalist and coronary person, and he's been part of our symposium for the last 3 years, has contributed multiple cases and discussion for us, and we're very grateful that he took the time really out of his busy practice to come all the way to Manhattan to join us. Again, just an introduction of our crew, as you all know them very well. Ray Lascano to my right. We've got Dr. Kapoor, Vishal Kapoor, who's our director of Mount Sinai St. Luke's in the endovascular side. Haroon Cameron, our endovascular fellow this year. And we've got Elizabeth and Damien here and our entire AV crew. We've got a really interesting case, and I just want to give you a little background to this case before we get started, because Vishal and I spoke about this case, and he asked me, like, why are we doing this case? You know, it's not particularly a very challenging case, at least for the ones that we've done in the past, but it's clearly something that I think needs to be discussed in a manner, and I'm glad that Dr. Ferrugia is here, because I think it's important to see what other people are also doing to take care of these cases. We always kind of show you a one-way, ticket, I guess, on what we do here at Sinai, but I think it's interesting to bring about different topics. So it's before I get to that, I'm going to have Haroon go over the history, and we'll go over the angiogram, and then we'll get to our discussion. Haroon?
Can you put up the slides, please? Next, please. Hi, good morning, everyone. So our patient is a 68-year-old female with a past medical history of hypertension, diabetes, hyperlipidemia, and smoking. She presents with bilateral low extremity lifestyle-limiting claudication, that is more on the left. Despite being on optimal medical therapy, her medications include insulin, aspirin, amlodipine, metoprolol, lisinopril, atorvastatin, cilostazol. As part of the non-invasive workup, she had ABI with exercise done. On the right, the baseline ABI was 0.95 and dropped to 0.89 with exercise. And on the left, the ABI was 0.92 and interestingly dropped to 0.67 with exercise. She had an ultrasound done that showed a long segment occlusion of the left SFA with patent vessels below the knee. Next slide, please. The patient had a subsequent angiogram done. As you can see, there is 3 pictures on the slide. On the left is the runoff of the left lower extremity. As you can see, there's a long segment occlusion of the left SFA that reconstitutes distally. And in the middle and the right skin are the DSAs of the proximal and distal cap. Next slide, please. So this is our tentative strategy for now, that we'll plan to go contralateral CFA access or ipsilateral pedal access if needed. Use a wire catheter technique for lesion crossing, true lumen versus subintimal versus subintimal tracking versus re-entry, and switching to an O3 wire system for intervention. And once we enter the lumen, the plan is to do balloon angioplasty, maybe a atherectomy, and stenting depending on the results.
So I want to thank Haroon for that presentation, but I just want a little background on today. You know, we've been getting a lot of emails and tweets and other things that I was talking to Dr. Farrugia about different situations in our field currently, and we've done now almost 100 cases. We'll be at 100 live cases next year around I think February or so. We'll hit about 100 cases. So a lot of the decisions and the questions I've been receiving by email have really been based on now how do we tackle lesions in the new era with the drug-coated balloon controversy. And I just want to, I want to ask Dr. Farrugia and Guja and Dr. Kapoor, so in this kind of lesion, Karthik and Peter, you know, let's start with Peter first. You know, when you see this lesion in your lab, Peter, you've got this long segment SFA occlusion in a lady who's failed maximum medical therapy with 3 vessel runoff. How do you approach this in terms of an interventional perspective? I mean, what are your thoughts and what are your decision-making points that you decide to do?
So I would say first and foremost, the biggest thing that you're looking at is how are we going to try and cross this? Obviously, we have pictures from contralateral access, and in a diabetic patient, we're clearly concerned that they're at a higher risk for restenosis. So if the discussion is centered around whether or not we're going to use a DCB in this patient, I think that she's got a higher probability of restenosing later on, especially with a long segment CTO. So I would lean more towards the utilization of either a DCB or a drug-coated stent like Illuvia, as opposed to something bare metal at the ostium. The other thing to really consider here is whether or not you know, you have excellent runoff below the knee. If taking a pedal approach here might make sense.
But why? Well, explain that to me, because that's kind of the reason why we wanted to talk about and bring that to it. Why would you take a pedal approach, and would you do pedal first? Because it's obviously something that's being done, and we want to understand why.
So I think that the move to go pedal first is to avoid growing complications. If you're having any concerns with the patient, you're going to be able to lay flat for a longer period of time if they're going home, and patient comfort on top of that. You know, you can easily control a complication at the foot with manual compression as opposed to a significant bleed from a common femoral stick. That being said, those of us who've been in the field for a long period of time, we've done thousands of femoral sticks, so we should be able to get into the artery under appropriate ultrasound visualization first.
So when you say pedal first, I think this is a great conversation. When you say pedal first, do you mean access pedal and treat via pedal as well?
I think so. I think there's a growing percentage of our population's interventionalists that are trying to go one stick and trying to go in either pedal or, you know, transradial is another opportunity for intervention, even down to below the knee at this point. I think that we still have some time for all the technology to catch up from a length perspective.
No, but I think Vishal would agree with me here. I'll let him comment. But you know, I mean, we use pedal stick. I mean, all three of us, quite liberally. But I think we use it more on a selective manner for crossing lesions rather than treating. So a couple of problems I have with pedal first is, first of all, I think that, you know, there's in a patient. You know, most people, like you said so nicely, going up and over, you know, if you use good technique, your chance of growing complications are incredibly low. I mean, even at a busy center of Sinai, we're under 1%, I would say.
0.6%.
Yeah, well, yeah, 0.6, as Vishal just said. So we do about 15,000 angiograms a year, and we're at 0.6% growing complications. So I think that's one that I don't really buy. But if you look at it from a technical perspective, here you have a patient. I mean, you're against the systolic blood pressure of 120. How do you identify the ostium? You know, I mean, what is it that you're doing? I mean, I know I've seen people go up, do roadmap from below, and then put a 6 French slender in to the foot, and then go ahead and deploy a stent. I don't see the logic in it, because I think that, you know, you can dissect the dorsalis fetus of the posterior tibial artery, and I just I mean, I'm not against progress, but I don't necessarily know that's not progress. But at the same time, I'm curious, Guj, what are your thoughts? And then Vishal, what are your thoughts? I can't hear you,
I mean,
Guja.
Yeah. Go
can
ahead,
you hear me
Greg.
now? Or?
Yes,
Yeah.
yes.
Okay. So I'm not I'm a big pedal first guy anyway. So I always believe that we are trying to protect the foot. It's not comparable to radials. We do radials in coronaries because we are not trying to protect the arm there. We are trying to protect the heart. So, but the target here is our foot, right? So using the target which you're trying to protect for access, really, I mean, theoretically, I don't know if it's agreeable or not, but I'm saying for these, you can use pedal first if in
Yes.
selective cases, as we said. If you want to use pedal first, you can use it in patients where you cannot access from above, like who have AAA grafts, whom you cannot do, you think it's okay.
Yeah, that makes
But
sense.
this case is going to be a prolonged case. You have to take all that into consideration because if this case, no matter how fast you do, no matter, it's going to take an hour for even the most experienced hands. So to put a pedal axis 6-inch sheet for 1 hour in a pedal in a dorsalis pedis, even if you have 3-vessel runoff, I don't know how much that's actually worth it. I mean, you could be the best interventionist in the world. I think you're still going to cause a lot of spasm.
Yeah.
There is a risk of thrombus. All these things have to be taken into consideration. I don't see the reason behind it. What are we trying to achieve here is the point, because we have clearly shown that we have a 0.6% kind of groin complication rates when we do it from groin. And you can put a 6 French from the groin and finish this case very
Very
easily.
What about you, Vishal? What's
Yeah.
your
Yeah,
algorithm?
I think I agree with the whole panel. It's all about case selection. It's like Karthik said, CTO case selections, you need good visualization from the entry point to the exit point, so that in that case, pedal might not be the best access. Maybe type A, short lesions, quick in and out,
Yeah.
and with a
Yeah.
3-vessel runoff, you could do a
Yeah.
pedal access approach. So I think it's all about choosing the
But
right
you know,
patient.
but for me, I don't think any claudican should be treated pedally. I mean,
I
I think
agree
that
with
I think the point of crossing is different, and I think that it's being, in my opinion, overused in the OBL and other settings. I think that there are OBLs that Ray and I know of who do only up and over and really have no problems. Patients go home the same day without an issue. So I just think that it's overused. But anyway, I don't want to over beleaguer it. Let's talk a little bit about crossing. I mean, everybody's good at it. Peter, let me know what wires you use. Let me just tell you, as me and Vishal cross this, we're using an 014 command wire with a support catheter. Do you go 035 system, 018 system? What's the system that you use?
I'll usually use an 018.
Push forward.
Like I actually use a command
little
018
more.
wire. I prefer an angle crossing catheter just because of that
see, Ray?
braided tip gives you a little bit more pushability. I think it's interesting. So in this patient specifically,
Let's do a little bit.
the length of your CTO is obviously kind of the biggest reason to not go pedal first. If I completely agree, in a short segment CTO, a transpedal intervention could definitely be considered, especially with
a little bit lower.
a 3-vessel runoff, which is advantageous because you're a little bit more protected there. And you may have to go pedal anyway if you have problems crossing from above. But,
Well, it's funny because when I asked for the command wire, Ray started laughing because our algorithm is, and Karthik would agree with us, our algorithm has always been to use a 035 wire in these kind of lesions, So, I mean, I don't know, Karthik, I know you do a lot of different things. I mean, what's your algorithm here?
In this case, I've recently switched to 018 wires in SFAs. If it's
All right,
short segment
give us an
CTOs, I try to.
what is it called? Connect 250T.
For this one, I would definitely try an 018 first before we use an 035 because I think we can stay intraluminal. I think that will. I don't think that will decide what you want to do with the case. Per se for this case, but it's good to stay intraluminal because at least you can probably get an atherectomy and angioplasty result.
Well, before we get to the treatment, I guess the question would be like, I mean, you and I have debated this and talked about this since we've known one another. I mean, and Vishal also is also opinionated. I mean, everybody likes to say intraluminal if possible, but what I'm saying is, what difference does it make? I mean, Anwar has.
I don't think it makes a big difference.
Yeah,
I mean,
exactly.
in this era, I don't think it makes any difference.
I mean, Anwar has that one paper, which is again, I think it's published in JIC. It's really squirrely data, but I mean, he says it's got to make a difference. I agree. Intuitively, it makes sense that it may make a difference to be pulled back a little bit, to be intraluminal. But to me, I don't know. I mean, that's my only thing. Whoops, there's another Collateral. See, this is what I have a problem with. These kind of wires, they tend to go everywhere, and I think this is the kind of situation where if we just put Torque, please, if we just put a 035, get a loop, bang it down to the distal, and then be done with it, the majority of the case will be over in a few minutes,
Yeah.
But let's see.
You could loop the 018 as well, though. I mean, it's
Exactly. So the advantage of using the smaller caliber 014, 018 hydrophilic is, all these have micro channels. So you can go in and hopefully it finds the micro channel, it connects it. And worst case, you can upgrade to an 035. But sometimes if you're very aggressive with 035, now you created another sub-intimal place, and now getting back in sometimes can be challenging. I mean, not that you can do it. You have re-entry devices and everything to do that to help us.
That's good.
But starting with and then escalating, I guess, is usually my strategy. PK likes to go with the big gun straight up.
Yeah, I mean, to me, it's like, I decide up front, like, all right, I mean, what are the chances of us not stenting this? Very low. It's like, why am I wasting my time? I mean, let's just move forward and get it over with. It's like, I don't know. I can't curse online, but I can't do that. Anyway, give me an 018 Terumo M.
Nice. It's like bringing a knife to a gunfight. I get the.
Yeah, it's like I think like what I want everybody to know is, look, when you see that lesion, you should have an idea of what sheath, what wire, what thing that you're doing. We're trying something totally different here than I normally do, which just to kind of add a little something to this case, because I think we could have crossed it by now if we just use an 035 wire. But I think that the idea would be that it would sort of be let's cut to the chase, because the real decision making is not going to be crossing the lesion, because I think most of us now can cross lesions like this very quickly, but the issue will really be is, like, what is your final therapy? Did you flush it?
Yeah, I flushed it.
I don't think you flushed it.
I know you're going to cross this very easily, but the question is, what is your plan to do after this?
Yeah, and I think that's what I wanted to talk about. So, let's just cross it quickly, and then you flush it before you take it out, guys.
Yes.
So what I think that one is crossing is 018, 035 versus 014. Obviously, we never use 014. A lot of people do use 014. We just never use it here, rarely. I mean, below the knee all the time, but not above the knee. Already, I don't like where my catheter is pointing, because I'm already out of plane. I know that. I'm going to pull back a little bit, and I'm going to try to redirect. But the point here is that I think, crossing is not the real issue. The issue is going to be...
I think you can take that loop. I think it's fine.
Give me a roadmap and mag up a little bit.
So while you're trying, I'll ask Peter. Peter, so we have a couple of options, right? Plain balloon angioplasty, atherectomy and balloon angioplasty, atherectomy and DCB. Now we have an DCB, drug-eluting stent and a covered stent. Sure. What would you do?
So my approach here would be, as soon as they get through and cross, I'd want to try and drop a filter down into the popliteal after the reconstitution site, and then proceed with some level of atherectomy. Nice. And the level of atherectomy really changes as to whether or not, if you believe you're a true lumen or not, as to whether or not you're going to do orbital atherectomy. I know you guys are more in favor of directional, which I kind of stay away from in my own practice. Guys. I'm an orbital atherectomy guy versus laser. Here I'd probably consider orbital. You can
but Peter, one question. You're saying orbital, but one of the things that we know about orbital is when you're in the subintimal plane, orbital is not a good thing. Here, obviously, when you cross the CTO, you don't know whether you're subintimal, intimal, so on and so forth. So right here, obviously, we're probably both. We obviously we cross with a loop. So, the question is, I think we got to be careful telling the audience orbital, because I don't think orbital is an effective strategy here.
Here I would use because you had to cross with the loop and you couldn't.
But you know what?
Going back to the true lumen question.
But one question. I went through this with Gunnar when he presented the data of DCB in CTOs, and saying that intraluminal crossing, made a difference. The whole point is they never did IVUS. So unless you do IVUS, there's no way you're going to know whether you're intraluminal or true luminal. Why not? You're never going to know that. So give me a 014. What is it called? Spartacore. So I think that's the situation where you have to be careful.
Do you think atherectomy is even necessary here? Do you guys think it's necessary?
And I think that's a great point, Karthik. I think atherectomy is overused. In some manner. You've seen the data by the Wall Street Journal that just came out with that crappy stuff that came out about overuse and so on and so forth.
Right.
I think look, atherectomy is FDA approved. Atherectomy has, I think we all agree who do a lot of these. It's not going to be a final therapy because it as much as definitive LE may have shown some efficacy to atherectomy, we all know there's better options at this current stage than just atherectomy. So I think atherectomy can be used for vessel prep, for drug delivery, and that may be something we could talk about. But to use it as a standalone therapy is not, and I agree with you. I don't think it's necessary here.
So
my question, and this goes back to why I'm always in favor of trying to cross interluminally if possible, is where I would like to be able to prep a vessel as well as possible, due to the fact that you're in a very specific area. We're dealing with, I don't see dense calcium here.
And that's my point. So why do we need vessel prep, right?
Yeah, you probably don't need it here. The consideration may be, would you consider doing laser here? I'm not a directional guy. I know you guys believe in directional atherectomy.
Actually, Peter, in this case, we're not going to do directional atherectomy, but it's more about you and I both know there's no right or wrong, right?
Yeah, there's 1,000 ways to skin a cat.
Right. So what I'm saying is okay, I want to talk about our thought process to why we do what. Right. Sure. So one of the reasons is, you said vessel prep. Okay. So when I look at vessel prep, I look at a couple of things. I don't know, Karthik, what do you think of when you say vessel prep?
So vessel prep is a very relative word. It's a very loose term, right?
Right.
You can we talk. The only way I use vessel prep is two ways. If you don't want to stent, then you can vessel prep it because you're prepared not to stent it. You want to get a good balloon angioplasty result. Clearly, POBA doesn't work, so you can atherectomize and balloon, and you don't end up stenting it. You want a good luminal gain. That's why you atherectomize it. That's okay. Here. The second reason I would like to vessel prep is if you want a stent expansion. And that depends on what kind of stent you want to use, right? Any stent can need a stent expansion, but if you're using a regular self-expanding stent, you really don't need to vessel prep that much. You can always post-dilate it. But if you're using a stent like Sopera, then you have to vessel prep it. But if you're planning to use a covered stent, there is no reason to vessel prep. You can just balloon it with a regular balloon, put a covered stent in, and then just go crazy on the post-dilatation.
Or luminal.
So that's how I see it, PK. The question is, I think everything depends on what your runoff is, right? You have a 3-vessel runoff. Now the question is, atherectomy will you have to put a filter. You have to go through so many steps. And you add additional cost. Clearly, that becomes an issue, right?
But you have additional cost. So, Vishal, what's your definition of vessel prep?
Pretty much same thing. My goal is to have a good end result, meaning self-expansion, meaning luminal gain. So if you have a lot of calcification, then you need the adjunctive devices, atherectomies, laser, whatever you want to call it. But if you have here, like in this case, not that calcified, my vessel prep will be just good, stiff balloon angioplasty to get my luminal gain, and then whatever definitive therapy, whether it be drug-eluting balloon or stent or spot stent and balloon the rest stuff. It just depends. If you don't want to stent the whole segment, then you can find your spot.
DSA.
Spot stenting of the areas you don't like, and we can take it from there.
So what I agree with both of you, and I kind of look at it the same way as Karthik. I think vessel prep is really getting the vessel prepared and looking for my final delivery. But there has to be challenges to the vessel. Like right now, this is a non-calcified vessel. You have 3-vessel runoff. You pretty much, you did the IVUS. The IVUS shows that you have some dissection distally, and proximally you're okay. So you know that whole area. Play the IVUS, Damien. And you can see that in the IVUS that distally you have some dissection, but majority of the time you're interluminal, even though you went with a loop. So Damien's going to start the IVUS from distal all the way down, and you can see we're all the way at the level of the pop. You can see there's the 2 lumens there when we entered. Play it, Damien. And I think we should have done chromoflow, but it doesn't matter. We've got good flow anyway. But you can see there you have the flap, and there's the 2 lumens. And as you're coming back, you're going to see that you're actually true luminal over here with a heavy plaque burden. This is all dissection. And then you'll see now. See, now you're true luminal with heavy plaque burden right here. So there you go. From here on, you're true luminal with plaque burden, which is eccentric. So I think that, with debulking, you're not really going to be able to remove all this, and I think orbital atherectomy is just going to embolize some of this soft plaque, and you're not going to get the luminal gain. I think the only real atherectomy that you can use here, if you want to use it, is directional, and I think without the level of calcium, I don't think it really matters. The other thing is also, I'm going to have our friend go over the data, Haroon, but if you think about it, couple of things that you want to talk about is, what are the other options? Well, we talked about filter. So we have the filter algorithm paper with atherectomy here. Long segment CTO, we should use a filter, especially with one vessel runoff. 2-3, it's plus minus. You don't necessarily have to. So I think, what's our ACT? 336. Okay, so a couple of things that we want to do here is, I think Vishal and I have decided not to use atherectomy here. We're not going to use a filter here. We're going to do a balloon angioplasty and then talk about definitive therapy. But before that, I've asked Haroon to put together a lecture. We're just going over some of the data. We haven't talked about covered stent. We've talked about DCB. We haven't talked about long segment stenting. So Haroon's put together some stuff we've always we can talk about, but let him go over some of the data that he's prepared. So in the meantime, Vishal and I are going to go ahead and balloon angioplasty this. This is a
60120.
120. They're going to be longer, right?
So let me go through the rest of
What's
the
your
slides.
longest 6.0, guys?
So the SFA CTO lesions are frequently encountered. 40 to 50% of the patients
They have
present
250,
with
I think.
CLI and claudication.
That's all they had in the back.
These are classified as task D lesions. CTO revascularization of the SFA is feasible with the use of
250 is nice.
different techniques such as wire catheter and dedicated CTO crossing and reentry devices. We'll go through those devices in the subsequent slides. Next, please.
250? All right, give me the
This is
5
an example of the SFA CTO crossing techniques. There's a number of factors that go into the choice of technique used. If you look at the figure on your right, for a SFA CTO lesion, there are a number of factors, as I mentioned earlier, which includes proximal cap, distal cap, the CTO body, CTO length, and a total lesion length. And on the figure on your left, you can see there are 3 different techniques that we can use, such as wire catheter technique in figure A, crossing devices in figure B, and subintimal tracking in figure C. Next slide, please. So in terms of the crossing devices, there are a number of options available in the market currently. These includes a TruePath, Frontrunner, Crosser, and Wildcat. These devices work by exploiting the microchannels. Next slide, please. So in terms of the definite treatment options, we have endoprosthesis, plain balloon angioplasty, drug-coated balloons, which have gone through scrutiny since the recent meta-analysis from Dr. Castano's trial came out, bare metal stents, and drug-eluting stents. Next slide, please. So I'll go through a few of the treatment options
give me
in
the-
the subsequent
give me the,
slides. One of the trial I want
the
to mention
capital
is
section
the
for an O2
Vibrant
sidebar.
trial. This was a trial of
Give me the
comparison between
Navic Cross and the
endoprosthesis
Supercross.
versus bare metal stenting. This is a randomized multicenter trial that was up to 3 years of outcomes. There was 148 patients included in the trial. These included
Navicross.
complex SFA lesions, task C and D, and lesion length greater than 8 centimeters. There were bare metal nitinol stent implantation 76 patients that was compared with non-heparin Viaband stent endoprosthesis, in 72 patients. The pre-specified 36-month data showed no significant difference in restenosis rates between Viaband, which was 24.2%, versus bare nitinol stent, which was 25.9%. The p-value was non-significant, 0.39. The primary assisted patency, as shown on the figure on your left, was higher for the bare nitinol stent, 88.8% versus 69.8%. This was borderline significant, 0.04. The secondary patency rates did not differ between the nitinol stents and the stent graft. The numbers were 89.3% versus 79.5%. P-value was non-significant. Next slide, please. The next trial I want to bring up is the Y-STAR trial. This was also a comparison between endoprosthesis versus bare metal stents. This was a prospective, randomized, single-blind, multi-center trial. Included 141 patients with symptomatic peripheral arterial disease. Primary patency in lesions greater than 20 centimeters over a 24-month was measured, And for Viaban, it was 65.2% versus 26.7% for bare metal stents. The freedom from reintervention that included either TLR or bypass surgery in lesions greater than 20 centimeter was 80% for Viaban and 61.9% for bare metal stent in favor of
Really short
Viaban.
balloon.
For
Give
a
me the
long
126.
SFA lesions, Viaban showed improved primary patencies over bare metal stents without impact on TLR or clinical outcomes. Next slide, please. So now I would like to talk about the drug-coated balloons versus the PTA data. Although use of DCBs has been called into questions due to the recent signal associated with mortality, the DCB angioplasty application in long, calcified, and complex lesions has consistently shown remarkable maintenance of up to 12 months of primary patency with reduced bailout stenting. Two trials I want to mention for DCB versus PTA. Number one is the LEVAN 2 trial. This was a single-blinded randomized trial, included 476 patients with either intermittent claudications or ischemic pain. There was a 2-to-1 randomization to paclitaxel coated balloons versus PTA. The 12-month rate of primary patency with DCB angioplasty was superior to conventional angioplasty, 65.2% versus 52.6%. There was no difference in functional outcomes, death, amputation, thrombosis, or reintervention.
But this is for short lesions, right?
Short lesion, and then the IMPACT SFA trial, they looked at moderate sized lesions also. And then they had a follow-up trial for the IMPACT long lesion trial. I did not include it in the slides, which showed a good patency rates for patients who got IMPACT PTA. So for the IMPACT SFA trial, there was a 331 patients with symptomatic Rutherford class 2 to 4 FEMPOP lesions up to 18 centimeters in length. It was also a 2-to-1 randomized trial comparing DCB versus PTA up to 24 months. The primary patency for DCB was 78.9% versus 50.1%, which was statistically significant. The clinically driven TLR was 9.1% and 28.3% in favor of the DCB. Both groups showed similar functional improvement at 2 years. Next slide, please. So in conclusion, the recanalization of a long occlusive SFA disease, while challenging, is now possible in greater than 95% of cases due to the availability or advancement in new wires, crossing, and re-entry devices. The PTFE covered nitinol stents such as Viaban are useful as a bailout for perforation or the treatment of long lesions and ISR lesions. With longer lesions that are greater than 5 centimeters, stenting traditionally has performed superior to angioplasty alone and should be favored. And for ostial lesion, for the SFA, disease that extends into the popliteal artery or ostial lesions, where stenting should be avoided, atherectomy with low pressure angioplasty such as 2 to 4 atmospheres may be a preferred strategy.
1 second.
Thank you.
Nice job. So, I mean, so you've got the options of coverage stenting. We actually had trouble getting even though our Navicross went, we had a lot of trouble getting a 035 balloon down. So we're just going to go with regular 014 balloon angioplasty here. That was the tightest spot right there. You heard it pop there. I would go up again, leave it up for a little bit. So the question here would be, with the data that's been presented, what would you do? So let's talk about some thought process things. So one is there's going to be we saw we were interluminal for majority of the way, and I think we all firmly believe that it really doesn't make a difference interluminal versus luminal in terms of at least we don't have data to show any differences in patency. So and in the IMPACT trial, the same thing where they didn't have IVUS to show, especially Harun didn't present the long lesion data. The long lesion data showed a 45% provisional stent rate. Go ahead, DSA, with a patency or a reduction in TLR rates that were very, very low. Okay, so I think it was like 97%. What is it called? Reduction in TLR at 3 years with the impact long lesion data. So you can see here you've got dissection pretty much all the way down up to that distal area. The one thing also that he didn't talk about is a Zilver PTX long lesion out of Japan, which also showed a very real world cases, dialysis, CTO, heavy calcium, again, a very good patency rate as well. So now we've got all these options to choose from. And the question is, what is it that you want to do and what goes into your thought process? So I'll start with you, Karthik. What is it that you want to do? You've got 3 vessel runoff. You've got, let me show you the popliteal just so you see your landing zones. Ready?
Yeah, no, I already made up my mind when I started this case what to do. PK, but I would have actually ended up putting I would have preferred a covered stent for this case, PK. But now I'm shying away from that only because I think the dissection plane extends beyond that huge collateral. So I think you have to stent across that collateral. I don't think you can end it before that because I can clearly see there's a small dissection plane after that collateral. So I just don't feel comfortable stenting across that huge collateral with a covered stent, even though I know it's a 3 vessel runoff. That's what I was actually thinking in the beginning of the case, that this would have been a perfect case for 3 covered stent. But now,
but you know what? In argument, you also have another collateral right after that. So you have
I see that, but this is the largest one we have, right?
Yeah.
Yeah. The other one looks more like an SFA to SFA kind of collateral, which doesn't look like mainly a profunda one. So I would at this point of time, I would definitely stent it. There's no doubt about it. I would just at this point do a supera and probably do an alluvia. I'm sure you spoke. We all are speaking to patients about drug coated stents and balloons before the cases. So I would do an alluvia on the top and supera in the bottom. That's what I would go with.
Vishal?
Well, I mean, in this case, probably because it's a long segment lesion, I would prefer to use a drug. I mean, I know we talked about the controversy all the time, but in this case, especially head-on going in, talk to the patient. I would just probably use alluvia all the way. I mean, you could make a combination of supera, alluvia, but the alluvia data is, if you're committing to a drug, I would probably use a drug-coated alluvia all the way up and get it over. We're still above that popliteal, the P1 segment, distal SFA. So I think the supera and all, the patency rate is pretty much comparable. So instead of using half a segment drug, and it's a long SFA, I'll probably use a whole segment drug and get over with it.
Peter?
So this is where an interesting statement is going to bring us back full circle to our first part of the discussion. If you had pedal access, you could probably drop a supera up towards the ostium of the SFA without concern about running back into the common fem, because I would say at least at the distal edge of this vessel, where we're getting into that P1 segment, putting a supera there where you're going through the adductor canal back into the distal SFA would make a lot of sense. And then based on where you're positioned with your catheter, even in the best of hands, landing a supera perfectly coming up to the ostium of that SFA would be very difficult from above. So an alluvia would definitely make sense. And I've done plenty of cases where we've done exactly that, because I think it would make a lot of sense for this patient.
You know, so a couple of things that I gotta push back on. One is, I think, landing a supera at the ostium of the SFA does not really make a difference because the strength of the supera is in these complex flexion points. So at the ostium of the SFA, you don't really have that issue going on. So I don't know the value of putting a supera there, and we generally don't because of that reason. Second is, I know all you guys know about the Drastico trial. So Listro, did a great job, and I saw him in Europe this last weekend. And, the 3-year data is coming out, but in 1 year, he's, I don't want to steal any thunder here. He kind of mentioned to me what it was, and I'll let the paper speak for itself at 3 years. But I think that at 1 year for sure, there's absolutely no difference between DCBs and DESs. So, and it's a randomized controlled trial out of Italy by operators that we all know very well, who are very good operators. So you had Drastico that just came out. It was published in JACC. So to me, I like that. Then I kind of go back and look at my own ideas of when to stent, when not to stent. I think the problem becomes is that we really don't know how DCBs fail. I mean, I've asked Medtronic for the data till I'm blue in my face. Hopefully they'll give it at some point. But the idea would be to analyze the ultrasounds and look at the areas where restenosis occurs in DCBs, look for dissections, so on and so forth. Most of us think it's dissections. Most of us think it's recoil. But the honest truth is we don't know. So why do DCBs fail? We don't know. But the one thing to know is that there's a 45% provisional stent rate in the impact long trial. So we don't know whether it's the drug-coated balloon or is it the fact that you had almost 50% stent rate, that the patency rates were so good at 3 years. So with all those great unknowns, what I tend to do is go back to my comfort zone, like my mother's womb, and basically say that, when do we stent? We stent when there's a flow-limiting dissection. Sure. What's the cause of restenosis? The cause of restenosis is intimal hyperplasia. What do we have currently against intimal hyperplasia is a drug. So the other thing that also makes me worry about stenting such a long lesion is we all have dealt with the thrombus within stents. We've all dealt with all the other nonsense that occurs once you have a stent, the fracture, so on and so forth. So what I want to propose to you guys is, why don't we do a drug-coated balloon here, long impact, 60250, and then go ahead and do a spot stent if we need to at the distal outflow with that, if we don't have that. That's what I'm kind of leaning towards, and I think Karthik and I spoke against atherectomy for a lot of reasons here, and so did Vishal. And I think there's no reason to put a stent. The other question is, there's been some reports of late aneurysm formation with the Alluvia stent. I know in Germany and other places. I don't know whether that's because of the polymer that's residing. We know that in Imperial, we did not have that reported by Dr. Gray and others when they did come out. Now, is this just positive remodeling and so on and so forth? We don't know. So, I think with Zilver, we have longer data. We have data in the registry with long lesions. So, I think that might be a reasonable thing. But for now, if it's all right with the three of you, I'd like to go ahead and use a long 60250 balloon. Do we have it, Damien?
Sure.
Come on,
Karthik, any thoughts on my thought process?
So,
No, I think it's fine, PK. My only concern is the proximal dissection, right? If you go to the previous picture.
Proximal or distal?
No, distally, I think you're going to spot stent the distal. I'm assuming that's what's running in your mind. My concern is that proximal dissection. I think that's actually more than distally. Distally definitely it's flow limiting. I think that proximal one is also flow limiting.
Well, it's not flow limiting, because the reason why I'm saying it, Karthik, is if you look at your shot, and I think for those of you at home, what fills first, the SFA or the profunda? The SFA beats the profunda down. So to me, it's not flow limiting. So if you had a significant lesion, then clearly the profunda would beat the SFA down. So, and plus we haven't.
But you have a wire across, right, PK?
Oh, no. That's what we'll do. We're going to balloon it. We're going to take the wire out. I know we can cross it again if we need to, so on and so forth. But I think at this stage, let's go with this, and then let's see how it looks, and if we need to spot stent. So what are your thoughts on this new stent that's out there by Dr. Schneider, a wonderful invention that he has with this, what is it called, intact vascular, which looks at these shorter stents, the TAC stent?
I have not used it, so I haven't used it, so I cannot comment on it. But
so we actually used one. It was interesting, Vishal and I don't know if Vishal was here, but I know he saw us use it, and I think it's a very interesting topic, and I think Peter, being the innovator that he is, sees that there's an opportunity for us to go ahead and use this for spot stenting. But I think the problem is we don't know when these lesions come back. Go up. So We're going to go ahead and dwell this for 3 minutes. The other thing also, for those of you who are concerned about the FDA mandate, one of the things that the FDA did say was high risk lesions. And this is clearly a high risk lesion. Go to 8. This is clearly a high risk lesion. Okay. So it's still not expanded in that one spot.
I know.
6, 7, 8. So this is so I know these aren't well defined in our endovascular space. What do you consider high risk lesions for restenosis?
Obviously, you nailed it. You have a long segment CTO. You have the patient risk factor. Even if you step back from the lesion, and you talk about the patient's overall risk factors, so if they have chronic kidney disease, if they're diabetic, they're more likely to restenose if they
Save
have
this, Michelle.
if this is second
Save
time
it.
that you're treating the
Yeah.
same lesion, it's more likely to restenose. And then obviously lesion length and severity of stenosis. So if you have a long segment CTO like we're dealing with now, your risk of restenosis is significantly increased over a small, short occlusion.
Karthik, any other
Right.
thoughts?
Also, yeah, calcified lesions, of course, right? I mean, I think most of the times when you have these patients, they are all
Over
fully
there.
risk factored.
You
But
can
I
start
think
it if you want.
long
Yeah.
segment, calcified, instant
No, tell them to
restenosis.
go.
I
Yeah.
think these are the three main high risk patients I
Go
can
ahead.
look at. I can think of.
Yeah, exactly.
Do you want to
Patients
add
with
anything else, Vishal?
No, I mean pretty much the same way. Patients with poor runoff, and of course the coexistent medical factors like Dr. Farooq talked about: CKD, diabetes, morbid obesity, uncontrolled
Yeah.
all the medical risk factors. But from an anatomical perspective, pretty much what we're dealing right now technically qualifies, according to me. Like you said, there's no definition, but based on experience, qualifies for a high risk
Right, so
lesion
I think you
intervention.
covered with the DCB on that manner as well. And I think here you really want to go with a little bit longer, prolonged. Rather than the 2 minutes, we'll go to 3 minutes. We'll reduce it to half pressure for the last minute, and we'll just leave it up for another minute. And Damien, we're going to need another 60 or what do you think? 60 or 80?
You got an 80.
Get an 80 DCB impact.
So PK, here's a question for you. I know you were mentioning before as a reason to not stent, um, in-stent thrombosis as a significant risk, which obviously it has been.
Not a thrombosis. The restenotic lesions in the stents contain significant thrombus. In our experience, we've had a lot, difficulties dealing with these long segment in-stent restenosis, which have thrombotic burden as well as fracture, so on and so forth. And we don't have that magic silver bullet as of yet to take care of these lesions. So that's what I was meaning.
My question to you is: Are you
Yeah.
using Xarelto 2.5 twice daily after you get through DAP? If you're putting a stent in, do you think that's going to impact the incidence of these partially thrombosed lesions in stent?
I mean, the answer to that is we don't know. Unfortunately, we really don't know what the right and wrong is. Currently, Vishal and I generally use that in difficult lesions where we are dealing with thrombus or a DCB or DES that's exhibited, thrombotic kind of clinical picture, and so we will start that. But obviously, it's not without a significant or risk of bleeding.
Sure.
In certain patients. So we do look at the has bled and other bleeding scores to see who may be the right person for these kind of things. So it's very difficult for us to judge. But I guess it's on a case by case basis, and by no means would we ever tell people. No, but you're fine. We got to do it up top. Yeah.
Sorry, yeah.
No means would we ever tell people to go ahead and do that. I think it has to be judged on a case by case. Little die, guys.
Absolutely.
So Peter, since you brought this up, let me ask you: How are you doing your rivaroxaban 2.5
go up.
milligram as a PAD after the Compass trial? Using them or no?
So I have been. I've been converting over patients if we wind up putting a stent in. I've always used a cocktail of 3 months of DAPT after a peripheral intervention. Because again, I don't think everyone does the same thing.
Yep.
How about the
Yes.
PAD
3
prevention
minutes.
from the Compass trial, the 2.5 milligram once
Right.
daily for the PAD patients? Not interventions, just coming with some as a part of OMT. Are you doing that? Not doing it? What's
So
your
right now,
practice?
right now, my practice, I'm adding the 2.5 twice daily for secondary prevention, not as a primary
Okay.
prevention
Oh, okay.
tool.
And I think it's
Nice.
interesting, here at Sinai, you always hear from me, Karthik, and Vishal about what we do, and it's interesting because I mean, our worry is that just like pedal access, that I think without enough data, without enough real indications, there's a lot of use of these meds, which we know that Compass was not an interventional study, so we're extrapolating data, and we need to be careful in that situation. And for the purposes that we think it's going to help, but we don't have any real data. So it's important to take it on a case by case basis. I think Dr. Farooja's point is very, very important in that in certain patients there may be a benefit, but we have to be careful.
Sure.
So right now,
I'm
go ahead.
Trying to use it as a secondary prevention technique after if you have to
Stent
put
in.
a stent in. You're providing the patient with DAPT therapy for 1, 3, or 6 months, depending on what your cocktail is going to be post-stenting. I mean, I think the COMPASS trial was really significant for secondary prevention in a lot of these patients. And again, bleeding is obviously a risk that always has to be taken into account. But I think, if anything, from a systemic standpoint, we're underutilizing a medication which could have significant improvement in morbidity and mortality.
Agreed.
True. Makes sense.
Okay, good. So now Ray's watching paint dry. Ray, how much more time do we have?
15 seconds.
15 seconds. So we're going to come down. Huh?
That's okay, good.
15 seconds to 2 minutes.
That's fine. Actually, let's go for 3. We're going to go for 3.
PK or
I think at this stage, let's look at the flow. I know if we IVUS, we're going to want a stent, so I don't want IVUS. And so I think what we're going to do is we're going to take a picture, and if the flow looks really good and we don't see anything really angiographically scary, pull the wire back, take another picture with some nipride or something, and then leave her alone. Let's put her on some.
this
medical
patient is a
therapy.
claudication 3-vessel runoff. I
Exactly.
think you can go either ways. You can always watch them with ultrasound. If they restenose, you can bring them back in spot stent if it's necessary.
Exactly.
She developed breast pain. Is that
No.
was that the history? She developed breast pain, or no? She's just pure claudication.
I think she's pure
Pure
claudication.
claudication.
I mean, she has 3-vessel runoff. I think that we get these referrals from all over, and I think this to me, for her to have breast pain is unlikely. She has a robust profunda collateral with 3-vessel runoff. I just don't. I honestly don't believe it'll be breast pain.
It's very unusual for them to have rest
Makes
pain.
sense.
Ready?
1 second. Let me get it off completely. So let me.
Good.
Okay. Ready when we
So
are.
we are going to go low mag here.
So Karthik, we're going to do your luminography. That's it. No IVUS for you.
That's acceptable.
Definitely some limitation of flow. You can see already. So Liz, give me a little nipride.
Interesting. All the way down to.
And this is
P1.
interesting because when you use a drug, you see this kind of weird little slowdown of the flow.
The
So
last
you
one,
wonder
okay.
whether this is liberation of that drug particles down below, and then we'll see how it looks. Give me another 100. Give me another 50.
200.
200 will drop it too much.
Oh, wow.
Give me another
She's
50.
167.
And this is where not having a big, stent is an issue. The other question is, now that you've drugged it, why not just use a bare metal stent?
Yep.
Well, that's Sapara is bare metal. You've got
No, I'm talking about one of the older
the
generations.
proximal lesion.
Go ahead, flush it.
Mm-hmm.
Why not just use like
Self-explanatory.
a what is that EV3 stent called? Not the EV3 Medtronic stent, the Protege,
Everflex.
Everflex.
Everflex. Why not?
Everflex.
I mean, you can use any self-expanding.
Listen.
I don't know.
It doesn't look very good.
You gonna pull the wire back now, PK, or?
No, because I wasn't
No.
happy with the flow, Gooch.
Yeah.
Okay. Yeah.
My pressure is now bottomed out.
Yeah.
That affects the flow too. Do 100 of.
No, don't do it. It'll be fine.
Oh, I mean, the blood flow.
It'll
will be
come
better
up by
once the blood
itself,
pressure
probably.
comes up.
Just a couple of seconds.
Yeah, the fluids are on. Just want to make sure the fluids are good. The blood pressure also, when it comes up, the flow becomes. better.
PK, I've observed over time. I mean, not as experienced as you are or Peter is, or neither am I experienced as Vishal, but over time I've observed that actually CTO cases, when you open up more than the CTO dissections, I think the native dissections become an issue.
See,
Yeah.
I think that there's your distal
After the-
flow
Yeah.
limitation. So I think we
Yeah,
need to
yeah.
drop a quick stent there. So
The
the
proximal
question,
one, did you look at it?
the proximal,
Yeah.
I think we'll stent the distal and then come to the proximal.
Yeah.
So
Yeah,
the,
as I said, the native vessel,
Super.
I think they become major issues. I don't know
give
why
me
that is.
give me a 6.0 short balloon, 6.050, 6.040
Yeah.
balloon.
See, your CTO segment seems actually okay, but
Yeah,
it's more your
the
native vessels
outflow.
which to get dissect. Yeah, outflows and inflows are the issues all the time. That's why I don't know how spot stenting actually works, because your outflow and the inflow become an issue. You're spot stenting in two separate areas, and you're leaving the main CTO segment in the middle just alone without stenting.
So this is interesting. So do you go? Is the problem? So this is where the IVUS is going to help us. Give me the IVUS, guys. So let's go live with IVUS. So what I'm thinking here is the problem proximal? Is that narrowing not significant because it didn't look significant before? We didn't balloon it. Is the dissection plane above the problem, or is it the narrowing the problem? So the only way
I think it's spiraled down from your CTO segment into the normal segment.
No, I don't know.
I think that was there to begin with.
I don't know. I'm actually thinking that you see that balloon, that dilated area with the dissection is the reason why we're not having flow. Well, let's see. We'll go. That's why we got the IVUS. Ready? Real? Okay, we're going down. All I care about.
I think there was that lesion before.
Comes until the level of the third collateral. So
I don't know. We'll see. IVUS, IVUS eyes are smiling, right? All right, so let's start here. Okay, no dissection.
Okay.
So okay, pulling back. Please. Record. Pulling back. So here's the collateral. Okay.
Right there on the right.
Now we're coming back. Just plaque.
Yeah, that's
there's no dissection.
That's your plane. That's your dissection right there.
Right there. Right there. Yeah. So this is what we have to stent. Yeah. So give us you know what? Give me a short balloon.
So the PK, what are you going to do with that CTO segment? That's what I'm trying to say, because your dissection spiraled from that segment, right?
Yeah, but if I tack up the distal, it shouldn't matter. So what I'm going to do is I'm going to balloon this first with a regular balloon. Well, we didn't DCB this area.
No, we did not.
So give me a short 6.0 DCB, 6.040 or 6.060.
Yeah, we didn't DCB this. We just DCB till the proximal segment.
Right, and then go ahead and give me a short 5.5 supera, please.
So what happens if you tack this with the DCB? Would you do an IVUS again if it's tacked?
That's a great point. Let's do that. I agree. Let's see. Don't open it.
No,
this one is fine.
Scientists here.
Well, I mean, look at this stage. We have to.
PK, I'm being a devil's advocate. I know how what you're trying to achieve here. You're trying to achieve minimal stenting. I get that point. But the point is, she's a 3.
No, I'm a believer in stenting. I mean, I'm not saying that. I'm saying that at this stage, we know what the problem is. We have a dissection, right? We've solved the area of the CTO. We're not going to stent that area. That's for sure.
You think that CTO is not going to recoil? Is that it?
I don't think so.
It's going to have significant recoil. PK,
I don't know. I think we have to figure it out. I mean, I'm not too worried about this.
The wire came back.
Yep, right there. Let's go up right there. So let me just balloon this and let's take a look and we'll decide.
In this case, I believe with Karthik, I'm a big proponent of inflow outflow to maintain the integrity of the whole CTO, because that's where all the problem starts most of the times. So, but we'll see. I mean,
so PK, I've observed that claudications. I think claudicants become claudicants when you have SFA disease. I get that, but I think they progress to rest pain with a good 3-vessel runoff is when they have profunda disease. If they have profunda disease, then they start going to rest pain disease, right?
Yeah, but this patient doesn't have
patient has no profunda disease.
Right.
So for her to have instant restenosis or anything, I think if she's going to develop restenosis, she's going to develop no matter what. But I think she's a perfect candidate for long segment stenting because she has good robust profunda, especially with robust profunda collaterals, which are 3 collaterals, right? And 3 areas of collaterals. And then you have 3-vessel runoff.
So what you're saying is, worst case, we start from 0, and if you end up in 0, and after 2 years, it's okay. If the profunda is fine.
I say that the DCB pattern of restenosis is more of a spot restenosis. So therefore, at this stage, what I'm going to do is convert this lady from an SFA who has a long segment occlusion to a spot restenosis, and then it'll be much easier to treat than treating a whole
focal SFA restenosis. Okay,
right.
That's
what
fair.
I feel. That's what I feel. But let's take a look. I mean, let's see how this looks. Again, at the end of the day, flow is going to be the determinant. I think at the end of the day, it's not about pictures. It's about flow. If we have good flow, then we know what it is, and we could even do something fun. We could do an IFR pullback. You want an IFR pullback? Let's do an IFR pullback. Well, let's do a lot of science here for Dr. Farrugia.
I appreciate it.
Let's do that.
Feeling the love all the way from Jersey.
Just give me an IFR pullback.
Question, right? Let's drop in. All of us are here, so let's drop in a question. Just out of fun sake. I mean, it's not like that's what we do, but something to look into. some patients like this who are long segment CTOs, they have profunda disease. Do you think achieving a good lumen in the SFA and in the profunda together, do you think is beneficial? Doing the profunda also, I'm saying. I know we are trained not to touch the profundas. I get that. But we have done we have achieved a lot of things since last 5 years
30 seconds.
in this field. The question is, ballooning the profunda, getting a good flow from both lines. You think that's because most of the times profunda disease are very focal, right? They're not extensive. They're more focal, ostial to proximal kind of diseases. You think ballooning both areas, ballooning the profunda also will make any difference for the patient?
No, because I think if you look at claudication, it's basically the genicular collaterals that are going to cause claudication in the calf, right? Calf claudication.
Right.
So if you have an open SFA, there's no reason for you to for you to balloon the profunda. I think.
No, what I'm saying is symptom-wise. I'm saying, let's say if they're focally restenosis, just because they're focally restenosis SFA doesn't mean the claudication is going to come back, right?
No,
we have seen it a lot of times. They become SFA CTOs, and then some patients still don't have symptoms. I think that's because they have a good inflow from the profunda. That's the reason they're not symptomatic.
No, I think they're not symptomatic. It's because they're conditioned, and that they have their whatever. You put it on DSA for me. I think they're conditioned and they don't have an issue in terms of their flow. I think that's the reason. They're going to come off.
Yeah, I am.
Okay, ready?
Yeah. The moment of truth.
Wow. I'm not going to stand that.
Ivis?
We'll pull the wire back now. Give me my my pressure wire. All right, so we're gonna do a little bit of science project here. Let's do an IFR pullback here to see what remember, it's all about flow. This is what I want everybody to remember. It's about flow. It's about pressure. So if you have a good pressure, right? If you have a good pressure, then and you have good flow, that's all you really care about. So let's get this wire down. Let's equalize and then take it from there.
PK, it's 9 a.m. I just want to remind you.
I know. The audience will appreciate this, because I think they'll start to feel that.
Do you want to take a picture of the proximal and see how that lesion looks on the proximal?
I don't care how the lesion looks. I want a flow. Okay, guys, let's zero this.
Yeah, but
I just want flow.
That's the lesion I'm talking about, PK.
Yeah,
that's the one.
Karthik, I will stand corrected if we have a pressure difference, and that's all I care about right now. All right, so we're zeroed.
I can guarantee you there'll be pressure difference there.
I hope so. Then I would say.
But then you would not know whether you got the proximal or the distal lesion.
I would say Guja's right as always. Torker.
No, if there is a flow lesion, we don't know if it's a tandem sequential flow lesion or is it because of one lesion because you don't know what's happening proximally.
Check this out.
Right.
Vishal, you're opening a can of worms here, so let's not go in there.
See, that's what Morton Kern will tell you. It's tandem lesions versus what it is. Oh,
We are trying to achieve a 1 full year of research in one conference, so let's not one talk. So let's not do that. So I think PK, if you want to do an FFR in this, I think I would suggest that you pull the wire out and then.
No, you can buddy wire. Buddy wire will help it go down, and then you put the other wire
down there.
Yeah.
Take with the
Yeah.
Just want to make sure we get there. This wire loops and twirls like the worst wire in the world. All right. Thanks, Ray. You're the only one who loves me, Ray. All right.
Don't get. Let's not talk about PT talk here, okay? We all love you. Everybody, even the audience knows that. Okay.
I don't know why I can't get it out of this
collateral. That's okay. I think there is okay, PK. You can leave it there, I guess.
No, you want the distal.
You're after that collateral, though.
I just got a little bit more distal. There it is.
The old man could still wire. Okay, good. All right, so now I'm going to take this out. I'm going to take the other wire out.
Yeah, you're good.
Okay. Now, do we have a gradient, Damien?
It's beautiful.
I just want to see a gradient.
Let's do an IFR.
So
Press on it.
no, we don't
But you
need an
have to run
IFR.
the
We're just doing
IFR.
a pull
No, you
bar.
have to
We're
run
just-
it.
No, we don't want
No,
to
you
run
can't.
it. Hold on, no. I just want to see if there's a
That's
resting
how
gradient.
IFR works,
There is no-
BK.
I
There's no
understand.
resting gradient on the IFR.
No, I can see the two pressures here, right?
No, but IFR is
I understand.
Okay,
IFR, you have
guys.
to run the IFR.
Run it now.
It's normal. See, PAPD.
It's
Look at the pressure.
It's normal,
3.
Chief. 1.0. So now I'm going to do a pullback. Ready?
The IFR
But they
didn't come
can't
yet.
be
I thought it came.
No.
It did, right?
1.0.
Oh, it's 1. Okay.
It's 1, yeah. It
So
came.
there's no pullback.
Okay.
We can't go more than.
Well, let's do one anyway for our knowledge.
Fine.
Let's see what the difference is. Ready for pull?
Beautiful.
See?
Good.
All
No,
right.
don't get.
0.34.
No,
DSA?
that's just a.
DSA?
Yeah, hold on. All right, now your proximal lesion. Well, there's no IFR, so what's the point of doing a proximal lesion? See that? That's probably an over. What is it?
Let's see the runoff. The money's in the runoff.
The runoff looks beautiful.
I am leaving it, boys.
I agree.
That's all right.
I'm going to leave
I
it.
wanna-
Reasonable thing to do.
I'm going to leave it. Let's see how she does.
The only person who's going to be happy here, PK, is Wall Street Journal article. So that's the person. That's the only people who are going to be happy about this. Because you
Why?
did a plain balloon angioplasty. Because you did a plain balloon angioplasty. You avoided stenting. You avoided atherectomy.
Oh,
the
it's not a
only
plane, it's
person who's going to be happy is Wall Street Journal. So
It's
good luck to you
drug-coated
then.
balloon
It's
angioplasty.
drug coated balloon.
Inject.
Trust me.
They don't care, right? As long as we don't bill for it, they don't care about it. So that looks like the all they care about is insurance companies. They don't care about the therapies. They don't care about anything else. So
I
guess-
think that there was a lot of logic used in coming to these decisions, and I think at this stage we're going to go ahead and stop. We're going to go ahead and not stent this because we have good flow. There was a little gradient on IFR pullback that I saw that Vishal didn't see. But I think what we're going to do is we're going to go ahead and put this lady on aspirin and Plavix and follow her.
I think she can be put on Xarelto, PK.
I kind of
2.5.
agree. I kind of agree because of that dissection. I probably will do that, and then we'll take it from there. We'll follow her in clinic and we'll see how she feels.
Beautiful.
Great
All right.
job.
So I want to
That's
thank
a
Dr.
great teaching
Farrugia.
case.
Well, it's a lot of discussion. I want to thank Dr. Farrugia for taking the time early morning, getting up and joining us here at Sinai for this wonderful case. Obviously, Vishal, Karthik, and Ray and our team for everything that they do for our program. And I think we will see you next week. Karthik, why don't you close it up, buddy?
Thank you.
Yeah.
So tell them when the next case is.
Yeah. All right. Thank you guys so much. It was a very interesting case. Thank you, Dr. Krishnan, Dr. Kapoor, for a wonderful case from the lab. I would personally like to thank Dr. Farrugia for coming here as a moderator today. Very interesting discussions. We have seen multiple thoughts of how things can be approached. I know there are multiple ways of doing things, even in coronaries. Same way in endovascular. Everybody has their own style of doing it. There are some certain things which are definitely wrong, but a lot of things are in the gray zone where you can go either ways depending on your experience, if you're experienced enough over the time, and what is right for the patient, of course, at the end of the day. But thank you so much for coming. We're looking forward to seeing you again next month on November 27th, the day before Thanksgiving, on the last Wednesday of the month. This case will be archived later today in ccclivecases.org. Please do ask any questions you have. We'll be more than happy to answer the questions as promptly as possible. Thank you so much. Have a wonderful day.
Have a great day, everybody. Thank you, sir.